And good evening, everyone, and welcome to the clinical webinar series, tonight sponsored by Corneal and Oculus. My name is Dr. Bill Tulo, Medical Director and Chief Medical Officer at Oculus, and I'm really excited tonight to welcome back one of our great previous speakers, Dr. Brandon Ayres. Before we go into the title of today's presentation, a little housekeeping. If you have questions, please place them in the chat, and we will do our best to get to them at the end of the presentation. And a recording will be available in about a week if you want to rewatch any parts of this webinar. Tonight's presentation by Dr. Ayres is the collaboration in keratoconus treatment, CTAK with Corneal and the Oculus Pentacam. Brandon, take it away.
All right. Hey, thank you guys. And thanks for attending the webinar. My name is Brandon Ayres. I am from the cornea service at Wills Eye Hospital and right now very chilly Philadelphia. And my private practice is called Ophthalmic Partners of Pennsylvania. And I wanted to bring, I probably have too much content, so we'll try and move through it pretty quickly, but how we use the Pentacam in the evaluation of our keratoconus patients and some of the surgical innovations in CTAK and how we're using those. So we'll get started. Now, I know if you're on this webinar, you probably already know this, but you have to go over a little bit of basics, right? We're going to be primarily talking about keratoconus here, which is that non-inflammatory thinning of the cornea. You get thinning of Bowman's membrane, progressive myopia, and irregular astigmatism. And it's still one of the more common indications for corneal transplantation, but definitely dropping. And that's likely due to the now earlier innovations or earlier interventions with collagen cross-linking. But we still have a lot of patients who need help. Maybe they don't want a corneal transplant, but they want something to see better. And what do we offer those patients? And that's where we've been offering CTAK. We definitely want to prevent this, which is high drops in a patient with keratoconus. So for a very long time, our discussion with our keratoconus patients was the same. It didn't change, and it wasn't very encouraging, and it would sound a little something like this.
Well, it's pretty clear on exam that you have a condition called keratoconus. Keratoconus is a situation where the cornea, which is the front of the eye, goes from being very spherical to being cone-shaped, and that leads to reduced vision over time. Now, unfortunately, this is vision that sometimes can't be corrected with glasses or regular contact lenses. You might need to use some kind of specialty contact lens. Over the next several years, you may find that this keratoconus gets worse. Right now, there's really nothing that we can do to help prevent that progression, and about 20% of patients will end up progressing so far that they end up needing a corneal transplant. That means you and I will end up going to the operating room. We will take off the misshapen cornea and we'll put on a new cornea. It may take a year, sometimes a year and a half to heal, but it should keep you with good vision. All we can do is watch, so I'll bring you back in a month or two and we'll recheck your prescriptions and see if things are changing. If it gets bad enough, we'll talk about doing surgery.
All right, so not a very encouraging discussion. And I love that in that video I call keratoconus a situation, not necessarily a disease. But really, there wasn't that much change in keratoconus management until about 2016 when we finally had FDA approval for collagen cross-linking. And you may have seen these papers where we saw less progression and even regression in our treated patients with progression in the untreated patients. And so that was really a game changer for keratoconus treatment. And we give a lot of credit to cross-linking for changing what we've done over the course of maybe the past 10 years with keratoconus management. But there were other things going on at the same time. So in 2015, in an office up in Teaneck, New Jersey, which is not too far from the bridge over to New York, Dr. Peter Hirsch was working on CTAK, or corneal tissue addition keratoplasty. So I think we kind of forget how long ago the evolution was, or the idea was, for these kind of biological tissue additive procedures. So 2015 was the initial IRB to start working on the process for CTAK. 2016, the first procedure was done. By 2019, we were getting more and more progress with the nomogram, and in 2020 was the partnership with Corneal and Vision Graft. early trials started, 2021, and 2021 was not that long ago. And then 2022, finally patent approval. And by 23, 24, and 25, we've gone to had some good early clinical trials. We have ongoing trials. And as of 2025, over 1,000 CTAK procedures have been performed. So I would say from about 2022 to 23, there was that early kind of rise in CTAK, and now it's just more and more interest in this tissue additive technology. And it's really been cool to see this procedure kind of move on. And I was a relatively early adopter in CTAK, and I think now we are in our second or maybe even third year of doing CTAK at Wills Eye Hospital. And so this is just something that we'll talk about again later. This is the difference map looking at somebody, pre-op with keratoconus, post-op after CTAK, and that centralization of the astigmatism and flattening of the central cornea. So really a nice way that we can, not only stabilize the cornea by using maybe collagen cross-linking, but actually reverse some of the keratoconus by doing CTAK, and how these two procedures work together. And central to this is being able to measure the cornea. So 2015, I think, was really a pivotal year. We were now not only able to stabilize the cornea, but also start the process or the idea of CTAK, which is now really moved into almost full swing. And maybe we'll be able to continue this with the approval of epithelium on collagen cross-linking. And I think it's almost impossible to talk about keratoconus and not integrate collagen cross-linking, diagnostic testing with the Pentacam, and CTAK. They are kind of three great flavors that all go together. So with this renewed interest, catching keratoconus early and stopping it matters. Being able to map the cornea, look at some metrics, and track progression has been really critical. That old story that I would tell patients of, well, you got keratoconus, we'll see what happens, and if you need surgery, we'll do it, has now really changed to, let's get you in early, let's get some diagnostics, let's see if we need to stop this from progressing, or let's definitely stop this from progressing. And if you've already progressed to a point where you're not happy with your vision, we may have some less invasive procedures to try and get that vision back. So central to this really is the Pentacam. And I think our office basically revolves around Pentacam measurements. And more, my technical staff, they just get a Pentacam on everybody. I'm like, well, I probably didn't need one on this patient, but thanks for getting it. But with keratoconus, every visit is a Pentacam. And I always, when I'm sort of having a huddle with my technical staff, I'm like, when in doubt, if somebody comes in and you think they have keratoconus, they have a story that sounds like keratoconus, they got something with a misshapen retina, because they always come in saying their retina has got something messed up, and I don't know why they're seeing a cornea specialist, it's probably the cornea, get that Pentacam. And I want to show you two different things. I'm going to show you a video of how we use the Pentacam, but I want to go over a couple of the screens that I like to use. Now, I use the Pentacam every day, and I'm still not what I would consider an expert in the Pentacam. There are so many different ways of looking at the data, but let me give you a real world look at what I am looking at, or what we're looking at in our patients with keratoconus. And one of the first images I like to see is just the 4 maps refractive. This is a really straightforward map. It just shows you what we are used to seeing on topography and tomography. I have it set up to show the axial and sagittal curve of the front. So basically just that the anterior curvature, what we've been looking at in topographies all along, looking for that crab claw or a truncated bow tie, or that typical color pattern that shows irregular astigmatism. And this is a patient who actually was just in today with keratoconus. Not only do we have the front map, which is the top left, we've got our rear curvature, right? Our pachymetry map, which I just circled in yellow. Then we have the elevation, which I have set to best fit spheres, to look for both anterior and posterior elevation. And posterior elevation has really become central in looking for early progression of keratoconus. So this is my quick one look. What do we have? Is it regular astigmatism? Is it irregular astigmatism? What is the pachymetry? Where is the thinnest point? And what does the front and back of that cornea look like? So that is the quick one shot. If I can only get one picture, that's going to be what it's going to be. Now, the keratometric staging is a newer readout that we're using, and this looks at the anterior, the anterior curvature, the posterior curvature, the thinnest pachymetry, which is different necessarily from looking at the apical pachymetry, right? Older ways of staging and measuring keratoconus looked at the apex of the cornea and how thin is it. Well, the Pentacam can actually measure where the thinnest location is and what that pachymetry is. And this is a static look at what the cornea looks like today. It's a little bit like the Bell and Ambrosio profile, but specifically for keratoconus. The Bell and Ambrosio profile really just shows you that D, the bad D, just shows you that this cornea may not be a normal cornea. It's not necessarily telling you that it's keratoconus. Looking at the Pentacam topometric KC staging shows you where that cornea is now. And I'll go through this again in a video, but this is one of the second things I look at, especially in a patient who's seeing me for the first time. And then the Bell ABCD progression display, this is a fantastic way of looking at repeated exams over time. So we're looking again at so the A is the anterior cornea, B is posterior cornea, and this is within the 3 millimeters outside the thinnest area of the cornea, and it's going to track this for progression. So each of those color bars is another exam that patient has had. So we can see if the anterior cornea is steepening over time. We can see if the posterior cornea is steepening over time. We can look to see what's going on with the thinnest point. Is the cornea getting thinner over time? And D is visual acuity. And you can tell here in my Pentacam, and this is real world Pentacam here, my office staff is terrible. That's user input. We have to put in what the vision is, and then it'll give us a bar. My technicians don't do this very often. They kind of forget about it, and I don't have too much time to go back and put it in. So admittedly, I often ignore the D and ABCD, but I rely on the ABC very, very much. You can also denote which, if you look down here, and I'll go over this again in a few minutes, but if you look down here, you can actually tell the Pentacam which image you want to use as your reference for looking for progression. And you can do that if, say, somebody was cross-linked and you no longer want to use their original kind of entry visit as a reference point for further progression, because now the cornea has changed shape. And if you look over here, I'll change the color to blue. And I don't have it in on this patient, but you can also denote where your cross-linking treatment was done in that patient's timeline. I'll show an image of what that looks like in just a slide or two, but this is just a great pictograph, right? You can really see what's going on over time with your patients, what they look like when they came in, where you did your collagen cross-linking on the right or left eye, and what's gone on with their cornea afterwards. I spend a lot of time looking at this display in those patients who we've been seeing for several visits or have had in for cross-linking, and in patients who we are evaluating for potential CTAK. Now, this is what I was talking about. This is a patient, and this is not my patient. This is an example slide. But this shows a patient who's been in the office and had 5 different exams, and they were cross-linked. So you see down here, you can denote when that patient had their cross-linking. And let me just bring your attention to these error bars. We've got well, in this case, we've got red and blue. And I think in my previous slide, hold on a minute. In this previous slide, we've got green and red. The green confidence intervals are the confidence intervals for a normal population. So if you are seeing a patient and you're not sure they have keratoconus, or maybe it's a fairly normal cornea and it's somebody who's got a family history of keratoconus, and you want to know if they're progressing towards abnormal, that 80 and 95% error bar are what you're going to be looking at. If you're fairly confident that somebody has keratoconus or they do have keratoconus, the red error bars, if you are seeing progression into those error bars, you can be very, very confident that that keratoconus patient is progressing. So that's green is the normal population, red is the keratoconic population, And then after the patient has been cross-linked, the newest confidence interval is going to be the blue flag. So the blue error bars or confidence intervals, I'm sorry, will not even show up on your Pentacam until you've told the Pentacam that there is a collagen cross-linking treatment, and then it will wait a year after that treatment to show those confidence intervals. So if you want to see how somebody is doing, are they continuing to progress after collagen cross-linking, that's what those blue bars are for. So I stare at this screen and really try to do a nice job at keeping the screen accurate and up to date. And then the last thing that I'll look at is the difference display. The difference display is such an easy way of just comparing two exams or multiple exams to say, what did the cornea look like today and what did it look like on your last exam? And the software of the Pentacam simply subtracts the two and can show you if that cornea looks steeper today or flatter today. So in this patient, we've got two exams, one from April of 2025 and one from November of 2024. And when you look at that difference, you see that red spot. So the difference display is over here. I'll circle that in blue. This is what's gone on in the interval between those two exams. In this keratoconus patient, you can see that apical cornea is steeper. This is a clear warning or indication that we are seeing progression. This is a patient that needs to be cross-linked, and if they want to see better, maybe a good candidate for CTAK. Whether we cross-link first or do CTAK first kind of depends on the patient, how bad the cornea is, and honestly, I'm not sure which way is the better way to go. We've had some patients, we've had a very hard time getting them cross-linked due to either cost or insurance issues, but we can usually get the CTAK done relatively easy. So sometimes we start there while we are continuing to work on cross-linking. That's a battle that we fight daily. So I made a video that I'll play with me actually at my Pentacam, and I actually wore a sweater, I didn't mean to, that matched the Pentacam perfectly. So we all match, and I'm gonna go over a little bit of how we walk through the displays on the Pentacam, and hopefully you find this helpful. Well, here we are in the office, and I figured no better way to discuss the importance of the Pentacam in following our keratoconus patients than to actually bring you in to our Pentacam. I mean, we use our Pentacam to initially screen patients. We use them to monitor, to screen for progression. We use it to see the effect that we get when somebody has had collagen cross-linking. And certainly we use the images to help us when we are planning out our CTAK procedures using the CTAK nomogram. So let's go over maybe a couple of patients in a couple screens just to show really what we do or what I do and how I think about using the Pentacam. So let's look at a couple of screens and let's see how the Pentacam can help us out when we are looking at our patients with keratoconus and maybe even planning some surgical procedures. All right, so I already have a patient pulled up in our Pentacam, and he's a patient who I know has keratoconus, and we've actually done cross-linking on him several years ago. One of the first screens that I like to look at is just simply the 4 maps refractive. It shows you the nice, I have it set up for the axial and sagittal curvature of the front. You get your pachymetry map. You have your elevation front and back, and it just shows you that typical picture that you want to see when you're looking at somebody who has keratoconus, just to confirm that you see either the truncated bow tie, or you'll see the inferior steepening, but it just confirms that your patient has keratoconus. And one of the next screens that I'm going to want to see is, especially when a patient's had more than one visit, is a comparison display where I want to compare, today's visit to before. And I think a really nice way of looking for progression is to compare one image to another, say 6 months apart or a year apart, or even just a couple of months apart. So in this case, when I'm looking at the right eye, comparing today's exam or comparing exam A to exam in the past, it just shows the difference. And I really like looking at that difference display because you shouldn't see a huge difference if somebody's cornea is stable. And if you see there's additional thinning in the cornea or additional changes in astigmatism, that certainly is a clue that your patient is having progressive keratoconus, which so many of our patients are. Now, another display that I really rely on is the ABCD, the Bellin ABCD progression display.
Okay, now this is the ABCD progression display, and there is a lot going on here. Now you can see that this patient has had multiple visits and multiple scans, and I can already tell you that he was cross-linked very early on. I think we did this cross-linking back in 2021. So as you continue to see your patients, this screen will build, and it's a very easy kind of graphical way that we can look at our patients to see if we think they're progressing. And there's a lot in here. Each different color is a different exam, and you can see the dates on the exam, and on the top you can see whether we're looking at the right or the left eye. What's also nice about this is you can pretty quickly flip from right eye to left eye without having to exit the screen. You can also show both eyes at the same time, but myself, I think that gets a little bit busy. So let's go back to the right eye. Now what you're seeing is A is in the 3 millimeter zone, the curvature of the front of the cornea. So we always think A is anterior. B is the posterior zone. So B stands for back. So front of the cornea, back of the cornea. C is thinnest location. And that gets a little confusing sometimes because after we cross-link patients, sometimes their cornea does get a little bit thinner. And so you want to be a little bit careful how you interpret the thickness. And then D is visual acuity. And as you can see, we've got a straight line along visual acuity, which really just means that our technicians don't input that for us, although we should. I'm not saying that's good. This is the real world, though. Sometimes we get a little bit lazy. But on the bottom part of this screen, you can see all the exams kind of lined up, right? And what you can do, and this is actually a slightly older version of the software. The newer version, you can actually input the actual date for cross-linking. But I'm going to uncheck where we did his cross-linking. So you can see when we do that on the screen, that little black bar is gone. Well, as we line up his exams, we check off where the treatment was, you know, between what two exams. And he was back in October of 2021. So between June of 21 and April, he was cross-linked, and that cross-linking was in both eyes. And now you can see our little line on the screen saying, hey, the patient was cross-linked here. Now, the reference image is going to be what all of the others are compared against. And so you can see this little blue bar. You can check where you think, what you want your reference image to be, what you want them all compared against. And since, you know, initially we typically just use the first exam when we're looking for progression so we can see somebody getting worse over time. But here we have a patient who's already been cross-linked. So I know that that cross-linking is going to change the shape of the cornea. So I'm actually going to select a new baseline image sometime after the cross-linking. And I like doing at least 6 months here, but here we can pick a year after his cross-linking. That sets the new baseline. Now, what do we see? Well, initially after cross-linking, he had... So guys, I'm going to fast forward my video because I'm kind of realizing that I'm saying the same thing that I already said in the previous. But I'll show you this case where we were deciding on a CTAK. So, you know, the starting exam is just looking at the four-mass refractive. You can see he's got a very typical keratoconus shape. Now, we've been seeing him for several years, and so we were able to build several exams in a library, and we could tell that he was progressing, and he ended up moving on to collagen cross-linking in both eyes not long after we initially saw him. And you can see in the Bellin ABCD, we can actually see that progression. So let's first take a look at the right eye. Now, his right eye was cross-linked in August of 2022. So once the exams come up, I'll show you August of 2022. All right, so he was using our baseline reference. You can see he was starting to progress from his first exam. We cross-linked him in August of 22, so we've already got our cross-linking bar up there. And we really should shift him to a new reference point. So August of 22, let's go about a year later in June. And it still looks like he's had some back and forth progression on the right eye. Although you can get some back and forth initially, but this is definitely somebody who we need to watch pretty carefully. And we are watching him carefully. Now let's take a look at his left eye. The left eye was cross-linked in October
of 22. So in between here, so we have our, so between June, so here is our cross-linking on the screen, and we're going to pick a new reference point for him after that. So October, let's do like December of 23. And it looks like now after his cross-linking with a new reference point, he's staying relatively stable in the right eye. Now, this is the kind of patient where he's asking for additional help. He's actually fairly stable in the left eye and doing pretty well, but wants some additional help on the right. And this is a patient that we just took and did CTAK on. In fact, I don't even have his new Pentacam after the CTAK because it was done just last week. But this is how we use the Pentacam to look at keratoconus, look for progression. All right, so I'm going to move forward here because now, basically that just shows how much time we spend looking at the Pentacam. And I now realize I was saying things twice, but I guess repetition is the key to learning. So with the Pentacam being the center of our diagnostic device and really guides our treatment algorithms, does this patient need cross-linking? Does this patient need CTAK? Does this patient need both? You have to talk a little bit about the surgical treatments for keratoconus, and we've got corneal transplants, DALKs, older intracorneal ring segments, but the focus here is going to be on CTAK. And the mechanism of action of CTAK is that additive technology where we're adding tissue to the peripheral cornea to try and get flattening of the central cornea. And for us, what we are looking for, patients with vision maybe best corrected 20/40 or worse, you want that pathology to be relatively central in the central 6mm zone, and that's what you can look at and you can see on the Pentacam. But we've really done cases even with relatively steep corneas, into the 60 diopter range, maybe even beyond. So that central cornea that's steep but not scarred, central pathology inside that 6 to 7mm optical zone, Pentacams and shapes that look a little bit like what you're looking at here. These are the cases that we are now transitioning over to CTAK. This is what the plan looks like for CTAK. So this is the map that you get back, and I'll show you how you actually upload your Pentacam U12 file right into the surgeon portal for CorneaGen. But let me just describe what you're looking at here, right? So after you send your U12 file from the Pentacam into the surgeon portal on the CorneaGen website, within a couple of weeks, you'll get this plan mapped back or sent back to you. And this has been run through the nomogram. And it'll show you the inner and outer diameter of the CTAK segment. It'll show you the thickness that's recommended. And in this case, the recommended thickness was 300 microns. And you can see that right here. All right, so there was our recommended thickness, but the surgeon does have the opportunity to say, you know what, I want to go a little bit thicker or I want to go a little bit thinner. So you need to confirm this map. There is some adjustability here. Now, typically I just go with what the nomogram says, but say you want to try and get a little bit more flattening, you could opt for the thicker segment. If for some reason you need to make your channel, which is typically at about 200 microns, if you need to go a little bit deeper, maybe there's a LASIK flap or a little scar and you want to make sure you're underneath that so you don't make a channel right into the potential area of a LASIK flap, maybe in a post-ectatic patient or a refractive ectasia patient. You might want to go a little bit deeper with your channel, but add a little thickness. So as you get more comfortable and confident with CTAK, you can begin making some changes. Now, truth be told, I don't make very many changes, but once in a while we will if we want to maybe go, we have a large pupil, we want to go to a 4.5mm optical zone, something like that. So it's not a set it and forget it kind of procedure. You do have some opportunity to make changes. Now, what you'll also see, and this is the image with the cornea, the channel is based off the center of the pupil, and there will be a little map that you measure from the center of the pupil down and over. And basically, you're just looking. You'll have to offset your pupil a little bit. So if you look over at these measurements here, this is saying you want to go from the center of your pupil down 2.1 millimeters and over 2.02 millimeters. Now, I can tell you from experience, that is a very minimal offset for your scleral tunnels, or your scleral channel, sorry, your corneal channel. Sometimes you need to offset that a little bit more if you're trying to stay away from your pupil, if you don't want to get the CTAK segment into the pupil. So you measure that new point, you measure that those three, you measure 3 different points, and with an optical zone marker, you basically draw a new pupil, you know, on your physical patient. I'll show that to you in a video, and that's what you center your corneal channels on. Now, what I have gotten a little bit more accustomed to, I typically use the LensX. Instead of necessarily marking on the cornea, I will dock on the pupil center, and I can actually measure basically that offset. I can go inferior to the pupil, you know, 0.1 millimeter and over 0.2 to try and replicate that offset. And that's some of the little tricks that you can learn as you get more accustomed. But certainly if you're new at CTAK, I would go ahead and make those measurements and measure that treatment offset. Clinical trials are underway currently, but consistently what they show is improvement in corrected and uncorrected vision. And it seems to be, you get, in our experience, has been, you get more flattening. The steeper the cornea is, the more flattening you're going to get. And here we see improvements in spherical equivalent refractions over the course of about, 1 month. You get a pretty good peak. 3 and 6 months, even more. We will be publishing some data pretty soon. Our poster is at ASCRS, so I can't spoil it yet for you. Looking at 1 month data, pooled analysis of multiple sites looking at CTAK. I really want to go out to 6 months, but we're going to report our 1 month data. It looks similar to what you're seeing here. After CTAK, you'll see a decrease in that mean K, flattening of the K max. And there you see that very important difference display on the bottom, looking at the before surgery with the steep cornea, after with the flattening. And what we traditionally see is centralization of the astigmatism and regularization of the astigmatism. And what really is miraculous to me is that sometimes the patients, the cornea doesn't look that much different on the Pentacam, but they are really much happier with their quality of vision. So let's look a little bit at some of the history of corneal surgery. The corneal transplant has been central to keratoconus management for years, but that is changing. If you're a cornea specialist, you've seen this image before. This is the very traditional corneal transplant. The first corneal transplant was described in 1905. And when I did my fellowship in 2005, this is pretty much all we did. Nothing changed in corneal transplant as far as the idea, the concept, for almost 100 years. Now, the eye bank was developed in 1945 with Dr. Payton, but what we did, taking a cornea off and suturing it back on, stayed almost the same. We are trying to avoid transplants because they're great, but they're not great. It's a 90% survival rate at 10 years, increased risk of cataract formation, glaucoma. If you're a corneal surgeon, you know that classic, see me in 2 months, we'll take out some stitches, we'll check your astigmatism. Patients, when am I going to see, doc? You're like, don't worry, it's coming. Anything that we can do, or anything that I can do to not have to do this surgery, is a major bonus. Now, there have been some changes, back about 2005 or so, people started describing the DALK really bearing Descemet's membrane, not just a lamellar keratoplasty, but a real deep anterior, and Amoir's big bubble, or you can do manual dissection. It's an upgrade, I think. There's less endothelial cell loss, but astigmatism is still a problem. And I've had some trauma patients come in, even with a DALK, and still have ruptures and expulsion. So although I guess DALK is an improvement, it's still not great. But we're moving forward. We're trying to make things better. And after we finish up this DALK, it's almost indistinguishable from a PKP, except it's the patient's own cells versus the donor cells. So that the treatment options early on were really the 3 tools. You got your glasses, you got contact lenses, and you've got corneal surgery. That was that discussion I had with patients, years ago. And now that's changing. Let me fast forward. 2004, we had traditional ring segments. I wrote the IRB at Will's Eye to start doing intacs. They were a hot topic for a while. The idea was really nice, you know, flatten that central cornea. Although I tell you, the intacs, I've been taking them out more recently than I think I put them in before. I'm not sure what's going on. Maybe after 20 years, I think we're starting to see some erosions over the PMMA inserts. Here's a picture of an erosion. We've seen a few infections, and even in patients who were doing well for years, I'm starting to see some issues. I'm not sure if that's just me. Maybe it's the cold weather in Philadelphia. But I just recently have had at least 3 cases of intact removals in patients who were stable for years. Luckily, even years later, they do come out relatively easily. And I have 2 patients coming up where we are taking the intacts out, letting the cornea heal, and then we're going to bring them back for CTAK, kind of a biological intacs. And infections can be an issue too. I did not mean to take that intact segment out. I'm going to fast forward here through collagen crossing. We mentioned this has been an improvement, but now CTAK. CTAK is really the biggest advance that I've seen in the past several years, the most exciting thing I've seen in the past couple of years when it comes to surgical improvement. I'll call it minimally invasive surgical improvement for our keratoconus patients. And it all does start with the right patient. Keratoconus, maybe post-refractive ectasia, but I would start with keratoconus. My rule, 20/40 or worse corrected. Clear central cornea, I like contact lens intolerance. You'll see here we're using our Pentacam to scan our patient. This is a real patient. I do have his permission to use his face in the video. We're going to get our imaging, and the Pentacam is going to be used to design and be put through the nomogram to design our CTAK segment. But you can just see my technician grabbing the scan. You can see on the image there, this patient definitely has keratoconus. You can see it in the image. This is a fellow who I've actually seen quite a while. But here we are taking that U12 file, and I actually slowed this down a little bit because it's hard to talk as fast as you can click, but we're going to take the actual image and you can download it to a flash drive, okay, in the U12 file. That U12 file gets uploaded into the CorneaGen surgeon profile, and you can put in the surgeon's name, you put in your email address, you upload that file with a little bit of data about the patient, and that's how we get the information to CorneaGen so that they can use the nomogram to help design the CTAK segment. Actually, learning about the U12 file, I did not know about the U12 file until a couple of years ago when we started planning CTAK, and I now use that U12 file even to transfer data between Pentacams. I see patients in a few different areas. So I got to thank CorneaGen for teaching me about the U12 file. It's actually made my ability to follow patients much, much better. But that's the file you want to upload into the surgeon portal, which is what you're looking at right here. I think you want to give them at least 4 weeks before your surgery. So give it some time. You'll get that planning map like you see right here, and if you want to make changes, let them know so they can change the profile before they actually send the segment to you. The segment is irradiated cornea and it comes packed in albumin. All right, so it's actually good on the shelf for several weeks. So I've had a case where a patient had to cancel due to elevated blood pressure. The cornea doesn't go bad. I just held it in the surgery center for him until he was ready to go. This is marking that cornea, marking the offset. I do this at the slit lamp. And we actually mark from the center of the pupil, following our map down, say 2.02 or 2.1, whatever the map says, to then remark with an optical zone marker where we are going to center our treatment zone. I would suggest that you use a fair amount of gentian violet ink on that marker because under the laser, it can be difficult to see. Now, we use the LensX laser. Not every laser can make a channel, but most lasers can. I believe right now the Ally cannot and the Catalyst cannot. But you can see here I'm able to, on the LensX, decenter our treatment to get to match the marked pupil, which really does not show up very well on the screen, but it was visible in real life. And here you'll see the channels being made. I think time in to time out in our laser room is probably, it's under 5 minutes. And I have the privilege of having a laser at our ASC where I do CTAK. You do not have to have them in the same place. You can do a laser a couple days before, even up to a week before it's been done at a laser center, and then go to the OR a different day. So they don't have to be done necessarily same day. This is opening the CTAK segment on the surgical field. And I will say that one of the more challenging things is actually finding the CTAK segment. It's packed in albumin. That little green thing on the surgical field is a strainer. We don't let, and I was just doing this with one of our fellows the other day, you don't throw anything away until you find the segment. I've had it stuck to my finger. I've had it stuck to the cap, but you need to find it. And once you find it, then you can get rid of the cap or the bottle if you want to. So I'm kind of looking in the strainer. A little tip, if you just touch the bottom of the strainer, it'll strain much faster. Still looking. Where is it? There it is. Okay, we found our segment. Now we can move on with the case, and I'll move over to the patient once I find it. So this is step one. It's like finding Waldo. Where's Waldo? It's where's the CTAK segment? It's been in there every time. It's there. Trust me. You just got to find it. A little bit of a look at what our instruments are. These are the clockwise and counterclockwise channeling dissectors. Looks a lot like the intact instruments from years ago, but they've been updated. We've got some forceps that are meant for placing the CTAK and smoothing the cornea. And I think it's actually pretty cool that industry has been very interested in making instruments to make CTAK more straightforward and easier. It really doesn't take a lot of instruments though. And once you get the hang of it, it's really quite straightforward. In the OR, we'll open our channels. This is just a little modified LASIK spatula. I'll go sort of clockwise and counterclockwise. Get the first maybe 2 clock hours open. This is that little spatula that we use. This comes with the instrument set for CTAK. Once we get that open, we'll take our clockwise and counterclockwise channeling dissectors. This is all done under topical anesthesia, a little bit of sedation, topical anesthesia. We're gonna rotate clockwise, and as you rotate, you want to wiggle that dissector. You want to open that channel because your segment's going to be, 1.5 millimeters or 2 millimeters wide. And there's not, unlike intacts where you could force the PMMA segment into the channel, with a CTAK you can't do that. It's got to go in there on its own. All right, you can't force it through. Now we'll go the other direction. This is one continuous channel. So once they connect, you're all set. So we got our channel made. And now what I like to do now is I actually have the CTAK map, I call it, hanging in the OR where I can see it. So I know where my incision is, because they tell you what axis to put the segment at. So I can map out where the CTAK segment should be, and I've got a little overlay showing what the map looked like. And I use a toric marker to mark where the approximate beginning and end of the CTAK segment should be. Because when you place the CTAK segment into the lamellar channel, it sort of scrunches up on itself, and you'll use a little smoothing device to sort of smooth out the CTAK, and it's going to extend its way around that channel. But I want to know about where it's supposed to end, so when I know when I have that CTAK segment completely kind of relaxed into the channel. These are the inlay forceps. These help to introduce the segment into the channel, and you'll see a little kind of hand over hand move, because initially that CTAK segment is going to want to back its way out of the channel. After you get a couple clock hours in though, it's going to continue to move around. But you might be able to tell that as we introduce the CTAK segment, it's not completely extending around the channel. It's kind of wrinkling itself up a little bit in there. So we're going to, as we introduce more of the CTAK segment, we're going to sort of smooth it and work it around the channel. And that's why I like having that beginning and end mark, so I know approximately when I have that segment completely relaxed. So here we are kind of ironing out the cornea. Whenever I'm talking to the fellows, I'm like, iron it more, push it in, iron it out, keep it going until we've reached our marks, and then we know we have the segment where it belongs. I think the first time I did a CTAK, this took me about 20 minutes. Now, from the time we do the laser to the time we're done, it's probably all in about 30 minutes or so, which includes even transit time to the from the laser to the OR. So really an efficient surgery. I use antibiotics 4 times a day for a week. I now use a steroid for about a month with monthly taper, very similar to what we use for cataract surgery. I don't suture the incision. I don't place a BCL. And this is your before and after picture. Now, here's our before Pentacam. Again, everything is based on the Pentacam, monitoring to progression, looking at the shape, and here's our after. Notice that centralization and more regularization of the astigmatism. That's what it looks like on the Pentacam. And and here it is on slit lamp exam, and there we have our before and after. This patient had a really great result, 20/80 with correction before surgery, 20/30 without correction afterwards. That segment is nicely opened. A little bit of haze in the cornea where the segment is, but not much. Looking at the difference with the older intracorneal rings, intacts basically were deeper into the cornea, and notice the prominent bowing into the cornea versus the more anterior CTAK segment where we've got more effect on the surface. And look at the epithelial remodeling. That bump in the cornea helps to smooth out the irregularity, and that's what we're consistently seeing. And I'm really trying to work with Oculus to see if we can look at that epithelial remodeling. Again, this is just actually a repeat of some of the early studies looking at the improvement in uncorrected and best corrected vision over time with flattening of the maximum and mean K. So now I think our algorithm for keratoconus is much more modern, all based on Pentacam measurements. Yes, glasses, then quickly moving on either to cross-linking or CTAK then cross-linking or cross-linking then CTAK. All in an attempt, and then going back maybe even and trying a contact lens, all to try and avoid the PKP, and all of it based on our Pentacam measurements and following. And yes, we have done CTAK prior to cataract surgery in keratoconus patients to try and regularize the cornea to decrease their need for specialty lenses after cataract surgery. That has also been quite successful. I wouldn't say I've got hundreds of patients, but I've got a couple. So even in that cataract age keratoconus patient, CTAK can be a benefit. And this is actually was one of our happier patients who's been doing very nicely after cataract surgery. So quick case, and then I'm going to call it a day. I think I've said everything, some things twice, maybe even 3 times. This is a fellow who I've been following just over the past, couple years, but he's been very active in the past couple months. 34-year-old guy. He's about to have his first kid. Best corrected in the left eye 20/70 with variable refractions. It's really hard to get him to get it stable. This is his left eye. The right eye is very, very mild, and he just wants to see better. And for whatever reason, we were having a really difficult time getting him approved for collagen cross-linking, even though here on the progression display, you can see over 2 exams, he was progressing rapidly. We were kind of hitting the alarm bells, but not getting anywhere with his insurance. But CTAK was relatively easy for us to get approved for him. So we said, you know what, instead of worrying about cross-linking right now, let's get his CTAK done. And you can actually see that 3rd bar. I didn't set my baselines correctly, but that 3rd bar is after CTAK. So you can see he was progressing and then rapidly improved. This was the patient's map. I making sure I covered up all of my HIPAA kind of data there. As you can see, this was a 500 micron segment. This is a pretty thick segment with a inner diameter of 4 millimeters and outer diameter of 8. So, and this is what it looks like on the Pentacam. You can see that relatively thick CTAK segment anterior in the cornea. You can see how it creates that elevation in the cornea, and the epithelium fills in the rest, and you get that nice smoothing of that apical thin area on the cornea, really helping to regularize his cornea. This is the difference display. You can see that really impressive flattening. I mean, we're at like 12 diopters of flattening in his cornea from one visit to another. A beautiful way of trying to reverse the effect of keratoconus. And we now have him down to functional vision at 20/40 with refraction of -4 +4 at 65. He's very happy and thinks that he could rely on that eye if he needed to. Still not his good eye, but he can use it again. And he's very worried about chasing after his new baby. I believe his wife is due in just a couple of days. So summing it up, and I'll leave a few minutes for questions. All right. The treatment of keratoconus has made leaps and bounds over the past 10 years. And central to that is our ability to image the cornea using the Pentacam. Right? We use that Pentacam to not only assess for progression, but also to help us plan out our surgical procedures, and it's used in the CTAK nomogram. Right? These additive technologies like CTAK are able to help with both mild and severe cases, and even in our cataract age patients, they have a lot of advantages over the prior generation PMMA inserts. I don't do Intacts anymore. I never will. I haven't done them in a while. It's CTAK, and that's it for me as far as additive technologies. And the Pentacam and these technologies are really critical at taking good care of patients with keratoconus. And with that, I'm going to leave a couple minutes for questions. Hope I didn't bore you guys too much. I hope I didn't confuse you guys too much.
Wow, Brandon, thanks so much. What a plethora of knowledge you shared with us tonight. This is really amazing. And we got quite a few questions, but as I go through them, we have more than 30 questions, but I think you've answered more than 25 of them in just your presentation alone. But let me ask you a couple of questions that maybe you can elaborate a little bit on. You did talk about doing cross-linking and possibly before or after, and it's inconclusive whether one is better than the other. But can you comment on the possibility of doing epi-on cross-linking? Now with Epioxia approved and other epi-on procedures in the future being approved, can you comment a little bit about the combination of epi-on cross-linking with CTAK?
Yeah, so a couple questions are often asked when it comes to cross-linking and CTAK. Now, I will say that I don't really think that it's any harder to do CTAK than somebody who's been cross-linked versus not had cross-linked. The cornea is not that much different. It doesn't make things more challenging. I'm very excited about epi-on collagen cross-linking. I mean, we have 50 plus patients already enrolled in the portal, and I think if you ask a patient what was worse, your CTAK or your cross-linking, hands down, cross-linking is worse. Epithelium off, it hurts for a couple days. CTAK, you get to the end of it and they're like, wait, you're done? And they go home like, I can see different the next day. I'm real excited about epi-on because now I think we're going to have two minimally invasive, very tolerable procedures for keratoconus where, I'm not talking about how the eye's going to get red and it's going to hurt and they have a risk for infection for a couple days. So very excited about combining the two. Now in our office, it'd be very difficult for me to do both epithelium on cross-linking and CTAK in the same day, but some offices are probably set up where they could do that. And that would be, I think, a fantastic way to treat keratoconus patients, kind of get everything done all in one day. But again, as you know, Bill, results are still not in yet, whether it's better to do one versus the other, both at the same time. We got to get all this stuff figured out.
Awesome. Excellent. Excellent answer. Could you elaborate a little bit? You mentioned that you typically go with the nomogram supplied by CorneaGen, but occasionally you mentioned you might go a little thicker if you want more steepening. When and if ever, would you ever go thinner?
I've never gone thinner. I've gone a little bit thicker sometimes. And we were actually just talking about pupil size, a couple of us, and when someone has large pupils, seeing if we want to go a little bit more peripheral. I suppose if you could go thinner if you're worried about overall corneal thickness or something, but I think I've never been tempted to go thinner. I've always been tempted to go on the thicker side. And it's a great question, and it just hasn't come up yet.
Excellent. I have one more question for you, and that is in regards to explantation revisions. How often, if ever, have you had to explant a CTAK or revise it in any way?
So here's the real truth. I haven't had to revise one yet. That doesn't mean I won't have to yet, or I won't have to ever, but I haven't had to. So in order to answer this question, I had to talk to somebody who has. So I reached out to Greenstein, Steve Greenstein, who has removed a segment. I think that the patient just wasn't happy and wanted to try something different, so we took it out and actually said it was quite easy to remove. I am sure at some point, for some reason, we'll have to take a segment out, but we have had enough patients who are happy with it that we haven't had to do it yet. So I don't have any direct experience myself, but when I do, I'll let you guys know. But according to Greenstein, he actually said it was quite straightforward. It did not strongly incorporate fibrose into the channel. He was able to open the channel and remove it quite simply.
Excellent. Well, we're coming to the top of the hour, and I think we've really supplied a ton of information. People will get the link to this if they want to rewatch it, and if you have any additional questions, we can certainly answer them via email. Brandon, I want to thank you for staying up late on the East Coast. This was really amazing, and I want to thank everyone for coming tonight, and we look forward to seeing you all on future webinars. Have a great evening, everybody.
Hey, thanks for having me.